Hi, everybody. My name is Lisa Howe, and today I'm going to be talking to you about intraoral dental screening, especially for our geriatric patients. So first things first, what exactly are we looking for? And this is just kind of a brief overview of our oral anatomy of our oral cavity. In addition to the teeth and gingiva, we're also looking at the soft tissue. So we're talking about the lips, the labial mucosa, the buccal mucosa, basically the lip and the cheek lining and the floor of the mouth, as well as a hard and soft palate. So for the lip and the labial mucosa, we're looking at the surfaces, the frenum, the vermilion borders, and the commissure and the vestibules of the mouth, and the major and minor salivary glands. So when you're first looking at it on inspection, we're looking at the color of the lips and the labial mucosa, the morphology, function, texture. You're going to be pressing on it a little bit. If there's anything abnormal, any weird lesions such as ulcerations, anatomic or developmental abnormalities such as a cleft lip, double lip, lip pit, or even a short lip. You're going to be looking for consistency, the pliability, if there's any indurated lesions, as well as glandular involvement, the texture of the lip, and the size and the shape of the lip must also be examined. So some of the more common lesions you'll be seeing are, your herpes labialis, erythema multiforme, smoker's patch of lip, and sometimes lichen planus as well. So here are some pictures. The top picture is angular colitis, which is inflammation at the corner of your mouth. It usually can cause by irritation or infection or allergies. And a lot of times in your older adults, it's caused by ill-fitted dentures and could be caused also by licking the lips and drooling, mouth breathing, which could result in dry mouth, and also exposure or exposure to sun and overclosure of the mouth, and sometimes even smoking and trauma. Bottom pictures right there is herpes, your common cold sore. And then the last vertical picture is a smoker's patch. So next on your buccal mucosa, first thing you're going to do is look for any potential abnormalities. You're going to feel around to see if there's any inconsistency in the texture. And then some of the more pathological condition could be leukodemia, leukoplakia, white spongy nevus, smoker keratosis, and some indurated ulcers. You're looking for the salivary duct openings as well, if there's any ulcerations and abnormal pigmentations. So here are some pictures. You see leukoplakia, leukodemia, and on the bottom left right there is oral squamous cell carcinoma. So any abnormal lumps and bumps. You're also going to be looking at the tongue. So the consistency of the tongue, especially if you see any tongue lesion, the resilience and the texture of the tongue, and if there's any presence of any induration, scars, or lesions. Definitely ask your patient to move the tongue around if they can. Make sure you're also checking the floor of the mouth as well. So in this picture, we kind of show how you want to conduct the exam. Make sure you're touching the floor of the mouth. Using a piece of gauze, ask the patient to stick out their tongue, and then check the lateral borders of the mouth as well, the tongue as well as underneath it. And basically also doing your oral cancer screening at the same time. So here are all pictures of oral squamous cell carcinoma that have been found in some of the patients. You could see that, doing a tongue exam is really important. Any abnormal ulceration, lumps, and bumps. Patients could also be really helpful in providing information during this time, because you can ask if they've noticed any of this lumps and bumps or how long it's been there. So now moving on to the hard and soft palate. By using direct or indirect light, conduct a visual exam, and you can take a look at the contour, the height, the area, the size of the papilla, the width of the arch to look for any weird lumps and bumps. So here in the picture on the top right, you see thermal burning. So, if you drink hot soup and accidentally burn yourself. Top left, you see candidiasis after wiping the white spots away. Bottom left, you see herpes zoster. Bottom right, denture stomatitis. Now, for the floor of a mouth, it can be inspected by asking, like we just mentioned, asking a patient to raise the tongue to reveal the structure and the different landmarks. The color of the mucosa covering the floor of the mouth should also be observed for any pathological lesions like granula, mucocele, ulcerations, or swelling. So here on the floor of the mouth, bottom picture, you see aphthous ulcer or your common canker sore. Bottom right, you see squamous cell carcinoma. On the right, you see a mucocele. When they're at the floor of the mouth or a little bit bigger, it's called a ranula. Basically, mucus cysts and generally caused by the minor salivary glands. Sometimes it could be also caused by lip biting as well as trauma. So now, of course, after we check out the soft tissue, we want to look at the gums and the teeth. For the gums, you want to take a look at the color, the contour, and the gingiva size. So make sure it's normal, no enlarged or gingival recession. For the contour, make sure the margin, the papillary, normal, rounded color, pink, red, bluish red, or any other color variation. So of course, we all know here's a picture of healthy versus inflamed. You can see that it's red, it's bulbous, whereas in the healthy, it looks pink. This is also a progression from healthy gums to gingivitis, periodontitis, and advanced periodontitis, which you could see a lot in some of your geriatric patients. Here we have the pictures of some gingival cancerous cells, so squamous cell carcinoma again. And then there's also pyogenic granuloma. Usually it arises in response to various stimuli such as low-grade local irritation, traumatic injury, hormonal factors, or some kind of drug. So that is on the right-hand side. So of course, when you see any weird lumps and bumps, again, ask the patients about it because chances are it may have been there for a while now. So the next thing, of course, we're going to look at are the number of teeth, caries, attrition, abrasion, erosion, any discoloration or staining, mobility, fracture, or broken teeth. And discoloration, if there's any dental plaque forming, food pigment or food debris, tobacco, smoking, or potentially could be caused by medications. Here are some pictures that we typically see by looking at the teeth. These are all geriatric patients of ours, 70 plus and older. You see some are wearing RPDs, some have a lot of recession with some inflamed gingiva. There's some in complete dentures. Those are complete dentures. Of course, we do want to remove them and then take a look at the soft tissue area as well. So the next thing I'm going to talk about is a brief oral health status examination, or the Bosch exam. This is typically something that we give community dwelling elders to take. They could be performed by a spouse or a caregiver. It assesses the oral health in the elderly individual. It covers the patient's current oral health status, including factors that could contribute to the risk of oral diseases and the need for referral. So it covers 10 oral hygiene categories. So it's looking at the lymph nodes, the lips, the tongue, the cheek, and the roof of the mouth, the gum, saliva, natural teeth, artificial teeth, chewing position, and general oral cleanliness of the mouth. So we usually recommend the caregiver or whoever's doing the exam to take a pen light or something that you can shine so you could see a little bit better inside the oral cavity. Use a tongue depressor so you can kind of like press the tongue down or move it to the side, gauze as needed. And then you're taking a look at the conditions around the oral cavity, and there is a rubric. So each 10 category is rated by the examiner on a 3-point scale. So 0, 1, or 2. So 0 indicates the healthy end, 2 is unhealthy end, and the final score is the sum of all the scores from the 10 categories ranging from 0, which is very healthy, to 20, which is very unhealthy. And the tool reflects the oral status of the individual. The higher score means that there are more problems that have been identified, although it should just be noted that the higher the score, if there is some abnormal lumps and bumps and abnormal things noted in the oral cavity, that we should refer to the dentist immediately. Now, for the caregiver, usually the time it takes to administer this exam is approximately 5 to 10 minutes with a report average of 7.8 minutes. So the next slide, you'll see kind of the category, the lymph nodes, talks about how to do the measurements, and then there's a score at the end of it. It also talks about whether or not the patient has dentures down here and if it feels comfortable inside the mouth. The resident's name, usually this is conducted in long-term care facilities and facilities where there are nurses going around. Examiner's name, the total score, and the date that it is scored. And then I think the rubric is really helpful, especially for somebody who may not know as well how to conduct the oral exam. So I really like this picture because it really shows the different areas that we should be looking and focusing on when we're conducting these intraoral screenings for our older adults. So here is my email. Thank you very much. Please feel free to email me if you have any questions, comments, or concerns. Thank you.